Okay. Okay, so today is November 17, 2022. So we'll have an SGD. Okay, we start at 10. Then hopefully we can end at 12 o'clock. Okay, but I just allotted 30 minutes for extra time. And then, of course, we have self-introduced each other already. Okay. And then you're aware of the learning objectives, right? Have you seen a copy? Okay. So anyway, if you don't have a copy, here it is again. Okay. So given the patients, which you were given one, okay. So the mentees provide the details, clinical data, clearly and concisely. So I like to emphasize relevant data. That's why I gave you a patient management process, which tend to be more concise, okay, more relevant when you discuss it, okay, unlike the traditional one, not the traditional format, okay. And then number two is provide a good history and present complete physical examination as one would proceed in a bedside preceptorial. Again, emphasis will be on the relevant data on history and physical exam. And then number three, give differential diagnosis and explain how the group arrived at the primary working diagnosis. Primary means the primary diagnosis or impression. Okay, and do it very efficiently as possible. And then number four, explain the pathophysiology of the disease at hand. You may include theoretical data or possible existing epidemiology of it. Again, emphasis is relevance. Provide options for additional diagnostic maneuvers or studies. It's in red. I just provided this one. It's lacking in your learning objectives. Okay, so I think there's a need to have this one, options, because medicine is not 100% all the time. Okay, there are always options available. The next one will be provide surgical plan, or if the patient does not need a surgery, then you would provide a medical plans or other treatment options. And then, of course, the last part of our activity will be the journal appraisal of a relevant clinical question regarding the management of the patient. Okay, so everything's clear? Can you raise your hands?
Clear.
Okay, clear. Okay. So now, Sandra gave me this list of the evaluation of the mentees. Okay, so it's quite general. I'll be focused on this one. Okay, so I will be evaluating your history and physical examination. As I said, pertinent negatives and pertinent positives. Okay, and then primary working impressions with differentials. Okay, summarize the salient features of the case, arrive and justify the primary working impression, and discuss the differential diagnosis. Usually the differential is just one or two. Okay, I don't like, I'm not fan of the long list of differentials. Okay, and then plan of management will be the diagnostics that are needed, or the so-called paraclinical, and then the preparations. Okay, so formulate the plan of diagnostic workups to confirm the primary impression if there's a need for one. If you're not quite certain, then you go for a diagnostic workup. If you're quite certain, you don't have to. Okay, then according to standards of care with consideration for cost efficiency. Okay, okay, cost efficiency. Okay, I think this was given to us by the department. So it, just like me, I emphasize on the cost efficiency. That's why in your table in the selection of the diagnostic workups and also the treatment, you have the BRCA, in which you have the cost there. Okay, that's inputted there. Okay, I suppose this is for time. This may be the first time that you're encountering such a process. No, you're now putting in the cost. Okay, then the plan of management in terms of therapeutics. Okay, or surgery if surgery is needed. Okay, viable plan for a therapeutic approach, whether surgical or medical or conservative or both, explains the rationale. And then post-op complications and prognosis, and then surveillance. Okay, how you're going to watch out for the immediate post-op course, usually within 30 days. That's our standards for surgery. Any complications that occur within the 30 days is still part of the surgical complications. Okay, then considerations on the surveillance and prognosis. Okay, everything's clear?
Yes, sir.
Serious po.
Okay, so these are the basis for the criteria for your journal appraisal. I suppose you know that already. Okay. Okay. So the grading will be individual instead of group grading. Okay. So mainly through active participation, answering questions from me. Okay. Asking questions to me, at least 2 questions per mentees. I encourage that. And then I will also consider your contribution to the case report and journal appraisal. Okay. So, Sandra, can you write down later on the contribution of each members to the case and the journal report? Okay.
Yes po, sir. We'll send po to you.
Okay. Have you been given a form that how you're going to evaluate me, naman? Okay. Okay. I hope you have a copy. Okay. So basically, I put there in. I won't read them anymore. Okay. I'll just put emphasis on the red lines. Explains the objectives, expectation, and various requirements of the course. I've done that. Okay. Make herself available for consultation. Okay. So this was given by the department. No? So I have to make myself available to you for consultation. Okay. So in this time of COVID, probably I won't be able to be there physically. Okay. And then number 15 will be use clear criteria to evaluate student performance. Okay. Okay. So I'll just make myself available through this online. Okay. You can message me in the messenger. Okay. And then email me, cell phone number, and then etc. Okay. Now, the last part that I want to tell you is that all of you have visited the YouTube on patient management process, I suppose. Okay, that has guided you in your discussions. Okay, later on at the end of the SGB, I'll give you a OSIL Olete on patient management process, which you're going to answer. Okay, okay, just like a quiz, but it's not used to fail you. It's just for mastery of learning. Okay. So if you don't get a perfect score in the first try it again until you perfect it. Okay. So OSIL stands for Online Collaborative Interactive Learning. OLETE stands for Online Learning Home Evaluation Test Exercises. Exercise. That's why there's an exercise. You just repeat the test until you get a perfect score. Okay, that's the end point of the OLETE. Okay, clear? Everything's clear?
Clear po, sir.
Okay, so we will now start the SGB proper. My proposal is that at least I've gone through cursory very fast kanina. Okay, your input, your output. Okay, your journal appraisal, and also the case presentation and discussions. Okay, so my suggestion: can we start with the case with the journal report so that we can get it out of the way now? Okay, then focus on the case discussions. Okay, so is that okay with everybody? We start with the journal. So probably we'll allot 20 minutes for that, or 15 minutes. Then the rest of the hours, the 2 hours, we'll focus on the case discussion, which is very important for all of you. No? Okay. So who will do the presentation for the journal? You can share your screen now.
Good morning, sir. This is Vincent Avella po, and we're going to present from the Journal of Research. So our clinical scenario po, of patient NE is a 52-year-old female with a 4-year history of right breast mass associated with occasional right breast pain. Breast ultrasound revealed an 8.8 by 9 by 6:05 p.m. fairly defined solid mass on the right breast. Patient underwent a biopsy which revealed keloidous tumor. He was advised to undergo mastectomy of the right breast. With this clinical scenario, our clinical dilemma or question is, among women with keloidous tumor, is adjuvant radiotherapy better than surgery alone in overall survival? So our population is women with keloidous tumor. Our intervention is adjuvant radiotherapy. Control is surgery alone, and the overall outcome is overall survival. Here's our first strategy. We use the following two words, keloidous tumor and adjuvant radiotherapy and overall survival. So we also, in our filters, we use free full text and 10 years. So this yielded these results, and we chose this journal article, the role of adjuvant radiotherapy in patients with malignant keloidous tumor of the breast, a propensity score matching analysis.
For
Okay.
appraising directness. Next slide, please. So we correlate the clinical scenario, the PECO of the clinical scenario with the PECO of of the journal article that we have selected. So the population on the journal article are the women with pathologically confirmed diagnosis of malignant phylloides tumor from 1988 to 2015. The exposure is adjuvant radiotherapy. The C or the control is surgery alone, or breast conservative surgery, and the outcome is improved overall survival and disease-specific survival. So does the study provide a direct enough answer to your clinical question in terms of patients, exposure, control, and outcome? The answer would be yes.
Next, we will discuss the validity of the study for our patient. So the study is a retrospective case controlled study, and the phyllodes tumor patients were identified from a database in the US, the SEER database, or the Surveillance Epidemiology and End Results database. So let's go on to the questions. So first, were patients randomly assigned to treatment groups? No, because the study type is a retrospective case controlled study. And so there was no random assignment done. Next was allocation concealed? No, the patients consented to the treatment procedure, either whether they receive radiotherapy or without. And allocation is not random. Next, were baseline characteristics similar at the start of the trial? No. So here is the table 1 of the study, listing down the characteristics between the two groups, whether those who received radiotherapy and those who did not. And they were described in terms of the age, race, laterality of the phyllodes tumor, the grade, tumor size, lymph node involvement, and surgery procedure, whether a mastectomy or a breast conservation procedure. Most of them were statistically insignificant, which is what we want for the table 1, except for 3 factors, which are the race, grade, and tumor size. So patients receiving adjuvant radiotherapy were more likely to be white, with better differentiation, and had large tumors. Next question, were patients blinded to treatment assignment? No, because patients consented with their treatment procedure, either they received radiotherapy or not, and they're aware of the treatment that they received. And this goes on, this is similar to the next questions. Were caregivers blinded to treatment assignment? Once again, no. And the next question, were outcome assessors blinded to treatment assignment? Once again, no. For the next question, were all patients analyzed in the groups to which they were originally randomized? Yes, because there are only two treatment groups, whether they received radiotherapy or did not. So even if they just received, so the duration of the radiotherapy was not explicitly defined. So as long as the patient received radiotherapy, they would automatically belong to the treatment group. Next question, was follow-up rate adequate? In the study, they found a median follow-up rate of the retrospective patients to be 99 months. So that's about 8 years. So it's greater than 5 years, the usual 5-year survival rate. And we think that this is a adequate follow-up rate. So next we'll be discussing the results, which will be done by Regina Rong. The next report is.
For the next question, how large was the treatment effect? So after the researchers performed propensity score matching, it was found that the survival curves generated showed that the patients did not achieve an improved overall survival or disease-specific survival from adjuvant radiotherapy since their p-values were greater than 0.05. So this showed no significant effect. Next, how precise were the estimates of the treatment effect? So looking at the multivariate analysis, specifically at the hazard ratios and confidence intervals computed, it showed that a poor tumor differentiation grade, larger tumor size, and lymph node metastasis were associated with reduced survival. While undergoing breast-conserving surgery was a protective factor of disease-specific survival and overall survival.
So next is appraising the applicability. So our question is, are there biological issues that may affect the applicability of the treatment? So in the study, the age and sex that were of the patients that were analyzed were less than 35 to 55, and greater than 55-year-old females. So our patient is a 52-year-old female. So it is applicable in our case. The race were as follows: white, black, and others. And this is also applicable to our patient who is a Filipino. There was no specificity of the laterality of the tumor, either right or left. The patient has a right-sided tumor, which is again applicable. Pathology, grade, the following were all considered: grade 1, grade 2, grade 3, and 4. So it is also applicable in our patient, as well as the tumor size, since the patient presents with 15 times 17 times 23 cm, and the surgery or the procedure that was done, which is both mastectomy and BCS. And our patient is currently for mastectomy. And adjuvant therapy, which the study groups received or did not receive radiotherapy. So as of now, the patient is not yet receiving radiotherapy. So again, it is still applicable in our patient.
For individualizing the results. So next slide. What's the likely effect of treatment on your individual patient? So the role of adjuvant radiotherapy is still uncertain, and as long as more than or equal 1 centimeter negative tumor margin is achieved, local recurrence rate is low. Next slide. Would you offer the treatment to your patient? For me, no, because adjuvant radiotherapy has not been shown to improve survival compared with surgery alone. Thus, I will not offer it to my patient if she has only a benign tumor, and also due to the lack of radiotherapy facilities here in the Philippines and cost, it will just be a burden to my patient that has uncertain benefits. That's it.
Okay. Can I see your reference?
Here po, sir.
Okay. Has anybody read about the local one, the one of Marco?
Yes, sir. We have found a study
Yeah.
by
Can you give me a summary of that one?
So sir, it was a retrospective study. They did a chart review. By the way, the title is Distant Metastasis from Benign Phyllodes Tumor, published in the Philippine Journal of Surgical Specialties by Dr. Ko, Dr. Nonan, and others. Well, so it was a retrospective study. They did a chart review from 2005 to 2014, and they looked up all cases managed in the Philippines, in PGH for Phyllodes tumor, and they found out that there was a total of 200 patients with Phyllodes tumor surgically managed, and out of those 200, 161 or 80.5% were benign, and though they also looked at which among those patients were followed up, and among those who followed up, there were 12 out of the 200, or 6%, who developed distant metastasis, and only one, or 0.62% of the 161 benign tumors had a recurrence of recurrent Phyllodes tumors.
Okay. Are you done? Okay.
Yes.
Okay. 6% has distant metastasis.
Yes, sir.
Okay.
But yes, sir.
What's your last statement? 1% is what? Local
1% had a recurrent benign
recurrence. What?
metastasis. A recurrent Phyllodes tumor, sir.
Only 1% out of the 200 out of the 200 had recurrence. Ganun ba?
Only, yes, sir. Only one case out of the 200.
One case has a recurrence in terms of local recurrence.
Yes, sir.
Okay. But 6% has distant metastasis.
Yes, sir.
Okay. You sure of the data, huh? Okay. So because we will input those local experiences to our journal appraisal, no? Okay. Okay, we'll leave that for a while. Okay. Okay, benign. Ito yung sandali, 1%. Locally recurrent. You sure? When you say 1%, it's only local recurrence, because distant mets is a kind of recurrence, right?
Yes, sir.
So yung recurrent na benign it's diagnosed as benign, and then you have recurrence. It's a local recurrence.
Yes, sir.
And then yung 1%, the one on the right side of the screen, yung those with distant metastasis, ano ito? Malignant?
Sir,
Malignant?
yes, sir. They didn't describe all cases, but they only mentioned the prominent ones. They one metastasized to the lung, and another one metastasized to the lip, sir.
Okay. But these were previously diagnosed as benign.
I will.
You're not sure.
I'm not sure, sir, but I think yes.
Kasi
sir.
yung 200 mo, it's 85% are benign, and then 15% are malignant, di ba? Right?
Yes, sir.
So, yung 6% with distant mets, where did it come from? From the benign one or from the malignant ones? Because your title is Distant Metastasis from Benign Phylloides, the title of the paper, di ba? Okay.
Yes, sir.
So most likely, it was initially read as benign, as diagnosis, and then on follow-up, there was 6% with distant metastasis.
Yes, sir.
Okay. Tama ba? That's how I like to
Yes,
interpret
sir.
it. Okay.
Yes.
Then, yung 1% recurrent, 1% recurrent, baka local ito, to contrast it to the distant.
Yes, sir. It's a recurrent local Phyllodes tumor, sir.
Yung 1% na yan, less than 1%.
Yes, sir.
Okay. Sige. Okay. Can you turn off your share screen? Okay, let's have a discussion. Okay. So when you do a journal report, journal research, now you look for some more information. So there must be a trigger from the case, from the patient. Okay. So it's just like a problem-based learning. No? So you encounter a question on the management of the patient, and then that will serve as a trigger for you to look up for more information in the literature, in the internet, etc. Okay. So that's what we call problem-based learning, okay, which we should develop a habit whenever we treat the patient, no? Okay. So maraming questions that will arise when we treat any patient, every patient that you will encounter, no? Okay. There's no such thing that we know everything about the patient, about the management, about the diagnosis, etc. There will always be questions on how to do it better, okay, or things that you still don't know that you have to look up, okay, problem-based learning. So in this particular case, pardon me, because as I said, I just look at it kanina at 9 o'clock when it was given to me by Sandra, okay. Was there a histopath diagnosis on this patient already? Naopera na ba?
Not yet. Pero meron po siyang histopath po, sir.
Okay. May histopath siya based on the core needle biopsy. Okay. So the
Yeah.
core needle is benign.
Yes po, sir.
Benign. Okay. So, okay, kung benign, okay, bakit niyo naisipan na as a question, as your problem-based learning issue, why adjuvant ang benign? Usually, di ba, run of the mill or the usual thing to think of, if it's malignant, then you consider yung mga radiotherapy. Di ba? Okay. Bakit?
Sir, clarify ko lang.
Okay.
Sir, yung incisional biopsy result ni patient, sir, it says there na merong suspicion for malignancy, sir.
Okay.
Since there's overgrowth of the stroma, hypercellularity.
Okay. So there's still a question whether it's malignant or benign. Is that what you're saying?
Yes, sir.
Okay.
Yes po, sir.
So incisional biopsy was done. A core needle biopsy was also done. Tama? Tama ba yan? Dalawa?
Only incisional biopsy, sir.
Walang
Only incisional biopsy, sir. No core needle biopsy done.
Okay. Only one. Okay. Incisional biopsy. Ano yung report niyan? Suspicious for malignancy? Oh,
Yes po, sir.
okay. So that's your basis, no? Okay. I suppose medyo you have to justify your kasi somebody will ask you, why do you consider adjuvant, di ba? Okay. So if you say, there's a suspicion that it could be malignant, no? So radiotherapy could be an option to add after surgery, okay? So at the moment, based on the run-of-the-mill thinking, it's acceptable, no? Okay. Okay. So, but if it's benign, usually you don't think of adjuvant radiotherapy anymore. No? Okay. Unless, okay, to justify it, as I said, nothing is perfect, nothing is absolute. New things can come out. You might be alarmed by the size, di ba? Laki-laki kasi yung tumor. Okay. Baka hindi matanggal lahat. No? There could be residuals, then you might add a radiotherapy. That could be a consideration, okay? Then in that case, you look up the literature, whether a situation like this is available, and then you can justify a radioactive adjuvant radiotherapy, no? Okay? So the size could initiate you to do to consider radiotherapy if it's too big, na baka hindi matanggal, no? Or at times, patients with local recurrence after a wide excision, total mastectomy of a phylloides tumor can undergo another re-excision, or if it cannot be excised, they just undergo radiotherapy. No? Okay. Okay, so that's for the issue on the trigger. No? Okay, but so anything that prop up in your management of your patient, and there's a problem-based learning issues, then you think of the question. What your question is: do I need to give a adjuvant radiotherapy if it's malignant? No? Okay, so you have justified it already. Okay, so it's nice to read the journals, you take a look, but you try to analyze it also based on the usual philosophy that is going on. Example, when you talk about radiotherapy, it's a local treatment, right? Local treatment. Okay. So usually phylloides tumor, usually malignant phylloides, usually they have distant metastases. Okay, so will radiotherapy help, since radiotherapy is a local treatment? Or it's much better to give chemotherapy, okay, as a systemic treatment? So that's a question that you have to ask, okay? Okay. So in this particular paper, they measure the survival rate in terms of what? Recurrence, distant, or local? Can somebody answer that question? Yung results, sino nag-present sa results?
Me po, sir. For the study, sir, they based most of the results on the characteristics of the patients. And then they just describe po their disease characteristics based on whether or not they receive radiotherapy po. But they mostly focused on characteristics such as the age, laterality or race, and the grade and tumor size of their and the tumor size and lymph node involvement po.
Yeah, they look at it, but it's after they see the outcome. Kasi yung conclusion ninyo is radiotherapy is still uncertain based on the study. Di ba? So, pero ano yung basis, ano yung parameters that they use? The local recurrence, kasi yan outcome would be local recurrence and yung survival. No? Okay. So, did they analyze the two or just survival rate? Kasi yung nag-present ng, I forgot who presented yung outcome, you said that survival rate is less than 8 years. Mga 8 years lang. So did they analyze the local recurrence?
In the the primary outcome were just overall survival and disease-specific survival. They did not check na specifically if there was recurrence. It was just the two factors. And then when they found out that radiotherapy had insignificant effects on those two outcomes, then that's the time that they checked on more characteristic and prognostic factors of this malignant phylloides.
Survival rate. So you saw the word survival rate in that journal. Okay. So they analyze the survival rate. And then after that, they look at the characteristics of the patients that can contribute to the outcome in terms of survival. So you also have to look at the local recurrence. If there's a local recurrence, it doesn't mean that automatically it will compromise the survival rate, because you can still reoperate. Yung mga ganon. So I hope there was an analysis there. Okay. Pero overall, anyway, so para whatever you read in the internet, you got hold of something, make the best out of it, kahit na hindi siya masyadong acceptable. Okay? So in this particular paper, okay, it made the conclusion already. No? It may not be as effective, as beneficial to add radiotherapy. Okay, based on the report, right? Did I interpret you right? Okay, and then you also think that as I said, pag malignant, the one that will kill the patient is the distant mets in phylloides tumor. Okay, so usually distant mets, and then the treatment there will be chemotherapy, di ba? Not radiotherapy. No? So if you want to avoid local recurrence, you can do radiotherapy, but before you do radiotherapy, the surgeon will make sure that they have an adequate margin to start with. Okay? Pag matanggal na yung tumor completely, cleanly, with a good margin, okay? So you may not have to give radiotherapy anymore. You just observe, just make a close surveillance. Okay? Okay? So ganon, no? So the lesson learned here from this particular journal is that at the moment, if it's benign, no, if it's really benign, you don't have to go for radiotherapy. No? Okay, you just observe closely. Okay, and then if there's a local recurrence, you try to, kaya maganda, importante yung close surveillance. No? Okay, so that if there's a local recurrence, you run after it right away. Okay, para you don't need radiotherapy. If it's too big already, then you may have to add radiotherapy to avoid another local recurrence. No? Okay? Okay, 8 years. So the last one here, yung kay mark ko, is that you can see that diagnosis, yung final diagnosis could be, just call it erroneous or baka na-miss lang, no? What could be interpreted as benign might turn out to be malignant after all. No? Okay. So yung 6% na yon is 6% na distant mets, most likely malignant yon to start with. No? Okay? So, okay. Before we close, okay, another lesson here, basta may diagnosis of benign phylloides tumor, it's not 100% benign. You have to have a surveillance. Na baka malignant siya. Na okay. Okay. So any question on the journal? Okay na? Can we proceed to the case discussion?
Yes po, sir.
Sige. Go ahead. Sinong magpe-present?
So good morning. For the case presentation, for the general data, patient ME is a 52-year-old female, single housekeeper, Roman Catholic from Angono, Rizal, who came in with a chief complaint of right breast mass of 4 years duration. So for the HPI, 4 years prior to admission, patient noted a 4x4 cm solid, mobile, with regular border, non-tender breast mass at the right lower quadrant, with no associated signs and symptoms. So no consultation was done. In the interim, no noted changes in characteristics of the mass, still not associated with any signs and symptoms. Until 10 months prior to admission, the patient noticed a sudden increase in size of the mass to 14 by 15 centimeters, still solid, mobile with regular border, but now associated with pain of 3 out of 10. So 9 months prior to admission, next slide please. So 9 months prior to admission, no changes in mass, but pain progressed to 4 out of 10. 6 months prior to admission, still no changes in mass, but pain progressed to 5 out of 10. So patient went to Hospital ng Angono, where she asked for a breast ultrasound request. 5 months prior to admission, with the same characteristics of the mass, the patient consulted at a private clinic in Taft, where breast ultrasound was done, with a result of right breast mass with suspicious features for malignancy, consider phyllodes tumor versus carcinoma, Byrad's category 4. Patient was then advised to undergo breast mass biopsy. So 4 months prior to admission, patient noticed that the mass border becoming irregular. So patient seek second opinion at a private clinic in Pateros where a breast mass biopsy was done. So 3 months prior to admission, patient went back to the clinic at Pateros since the biopsy result was available with the final diagnosis of phyllodes tumor. She was advised to undergo mastectomy of the right breast. Due to financial constraint, patient requested to be referred to another institution and opted to seek consult at PGH. So patient has no known comorbidities, no previous surgeries and hospitalization, no known allergies to food and drugs. The patient's father has hypertension and her late mother has goiter and there's no family history of cancer. So patient was a previous cigarette smoker, previous alcoholic beverage drinker, and denies illicit drug use. For OB/GYN history, patient is a G3P3 3003. She had her menarche at 15-year-old, irregular with duration of 5 days and uses approximately 10 pads per day and experienced dysmenorrhea. She had her menopause at 50-year-old, so last 2020, and had no history of OCP intake. So essentially, patient has a normal physical examination, except for the 15 by 17 by 23 centimeters movable firm breast mass with overlying erythema and without skin break, no palpable axillary node, no nipple discharge, and no skin changes. So other parts of the systemic physical examination was normal po. So here is the picture of the right breast mass. It measures 15 by 17 by 23 centimeters po.
We now proceed to the case management discussion. Next slide, please. Next slide. We now review the pertinent cues that will lead us to our clinical diagnosis. So we noted that the patient is a 52-year-old female with a rapidly growing right mass of 10 months duration, with breast contour distortion and associated pain 5/10. From her breast ultrasound done 5 months prior, it was found that the right and left breast parenchyma are homogeneous with no focal lesions seen on the left. On the right side, there was a 8.8 by 9 by 6.5 centimeter fairly defined macrolobulated hypoechoic solid mass. With the impression, right breast mass with suspicious features for malignancy, considering phyllodes tumor versus carcinoma, Byrad's category 4. Next slide, please. For her incisional biopsy done 3 months prior, the specimen consisted of 3 small pieces of gray-white, irregularly shaped soft tissues, approximately 1.5 by 1 by 0.8 centimeters. So it mostly had surrounding stroma that were hypercellular, composed of spindly to elongated cells, with around to spindly and hyperchromatic nuclei. Next slide, please. So knowing the history, PE, imaging, and biopsy results of the patient, we now have a primary clinical diagnosis of phyllodes tumor on the right breast with a secondary differential of invasive ductal breast carcinoma on the right. Previous slide, please. So phyllodes tumors are non-epithelial neoplasms of the breast and only represent 1%, approximately 1% of breast tumors. So these typically develop de novo outside of breast lobules and ducts, within the breast's connective tissues called stroma, which include the ligaments and fatty tissues. Currently, no chromosomal aberrations have been found to be specific for phyllodes tumors. However, there were previous reports that postulated that high-grade phyllodes tumors consistently showed a chromosomal gain 1q and 13q loss. The majority of these phyllodes tumors occur almost exclusively in females and predominantly in middle-aged women around 40 to 50 years old. Genetic risk factors of phyllodes tumors are not yet well known, but have been usually associated with Li-Fraumeni syndrome patients. It has also been proposed that growth factors may have a role in stromal induction of phyllodes tumors, which may be stimulated during times of trauma, pregnancy, increased estrogen activity, and lactation. However, the physiology behind this is still not well understood. Macroscopically, phyllodes tumors are typically well circumscribed, firm, and protruding with a characteristic whorled pattern. There may also be hemorrhages and necrosis present. Microscopically, they have a leaf-like architecture of elongated cleft-like spaces with papillary projections of stroma. These stromal elements are the main key in differentiating phyllodes tumors from fibroadenomas.
For the pattern recognition of our primary clinical diagnosis, we correlate the signs and symptoms from the case to the nature of phyllodes tumor per se. The blue text are the one present with the patient. Phyllodes tumor are known to be a rapidly growing breast mass and often unilateral. In some patients, a lump may have been apparent for several years, with sudden increase in size for weeks to months thereafter. Due to its size, according to UpToDate, may range from 1 to 41 centimeter. It may distort the contour of the breast and may compress the breast tissue. Also, it was reported that majority of patients who have phyllodes tumor do not complain of pain. Next slide, please. On physical examination, an enlarged, movable, firm, smooth breast mass may be appreciated with regular to irregular border depending on the subtype. The skin overlying the tumor appears shiny, tense, and congested. Nipple retraction, skin ulceration, chest wall fixation, and axillary lymphadenopathy of approximately 10 to 15% of recorded patients are rare clinical presentation of phyllodes tumor. According to Radiopedia, breast ultrasonography render non-specific on the definitive diagnosis of phyllodes tumor. A solid appearing mass containing single or multiple round or cleft-like cystic spaces may have been seen. Calcification are not usually present in this case. Grossly, phyllodes tumors are round to oval multinodular masses with a grayish-white appearance that resemble a head of a cauliflower. The appearance of both epithelial and stromal elements within the cytological smear support the diagnosis of phyllodes tumor. However, according to Mishra et al., epithelial cells may be absent from malignant lesions as seen on our patient. On the other hand, presence of stromal overgrowth, hypercellularity, nuclear pleomorphism, infiltrative borders, and increased mitotic figures vary depending on the subtype of phyllodes tumor, as mentioned in Robbins and Cochran pathologic basis of disease.
For the secondary clinical diagnosis, we considered invasive ductal carcinoma. Previous slide. Yes, thank you. So breast cancer is one of the most common cancers worldwide and is the leading cancer among women. In the Philippines, 26 out of 100 females are diagnosed with breast cancer. This has several types, and the most common is invasive ductal carcinoma, consisting approximately 70 to 80%. There are several risk factors to breast cancer. Increasing age is one of the most important risk factors of breast cancer. Its incidence increases with increasing age, usually beginning around 40 years old. Family history is also another important risk factor, as there is a 1.75-fold increase in risk with a first-degree relative with breast cancer, and a 2.5-fold or higher increase in risk when the patient has, or when a woman has 2 or more first-degree relatives diagnosed with breast cancer. This is highly related to the inherited mutation in either genes BRCA1 or BRCA2. Next, reproductive factors such as early menarche, late menopause, nulliparity, late age in first pregnancy, and estrogen or hormonal therapy can increase the risk as breast tissue is highly responsive to the proliferative effects of estrogen. However, patients who have already discontinued estrogen and or hormonal replacement therapy for more than 10 years have reduced risk of breast carcinoma. Lastly, lifestyle is another common risk factor to breast cancer. Increased alcohol consumption per day, along with cigarette smoking, increases the risk by elevating estrogen-related hormones in the blood. High-fat diet is also associated with a 1.3 times or 1.3 fold increase in risk and is also associated with poor prognosis among those already diagnosed with breast cancer. So in pattern recognition, like in the primary clinical diagnosis, those in blue are present in the patient, while the rest will be about expected findings or patterns in invasive ductal carcinoma. So for the symptoms, those with invasive ductal carcinoma are expected to have rapidly growing firm, immovable breast mass with irregular borders. This results to distortion of breast contour. It may be painful and it is also often unilateral. So the only difference here from the patient is that the patient has a movable breast mass, while in invasive ductal carcinoma is expected to be immovable. For the signs and lab results, the PE findings expected in invasive ductal carcinoma are the following: enlarged, immobile, firm breast mass with irregular borders, breast skin changes such as erythema, thickening, dimpling, nipple inversion, and podiorans. Axillary lymphadenopathy can also be expected if there is a local regional metastasis. And we can also expect to find some signs of distant metastasis, such as back or leg pain, nausea and vomiting, abdominal pain, jaundice, dyspnea, and cough. So for the patient manifested with enlarged, movable, firm breast mass with irregular borders and erythema. For the breast ultrasound, expected findings for invasive ductal carcinoma is a lesion with hypogenicity, internal calcification, shadowing, a lesion taller than it is wide, and spiculated, indistinct, or angular margins. So for the patient satisfies hypogenicity and presence of calcification. For the incisional biopsy, expected gross findings include hard, gray-white, gritty masses invading the surrounding tissue in a haphazard manner, creating an irregular stellate shape. For the microscopically, hordes and nests of tumor cells with varying amounts of gland formation are expected in invasive ductal carcinoma. So given these findings, given the pattern of invasive ductal carcinoma and the patient's history, PE, and lab findings, invasive ductal carcinoma can be considered as a secondary clinical diagnosis.
So for the paraclinical diagnostic procedures, next slide. Next slide. So for us to be certain of our diagnosis and to know what type of breast mass the patient has, it is imperative to work up this patient because the treatment plan will vary based on our paraclinical diagnostic procedures, such as in our primary diagnosis of phylloides tumor, in which the treatment modality is surgical, and invasive ductal breast carcinoma, in which surgical with chemotherapy with or without ROJoson therapy is needed. Next slide. So this is just an algorithm showing what to do in patients who presents with a palpable breast mass of more than 40 years old. Next slide. So for the first paraclinical diagnostic procedure is the imaging. So breast ultrasound is not typically used in routine screening for breast cancer. So but it's used in patients who has a dense breast tissues and in defining cystic masses and demonstrating the echogenic qualities of specific solid abnormalities. So ancillary imaging techniques such as MRI may also be necessary to assess the posterior tumor extension and pectoralis, fascia, or muscle involvement, if that will determine a change in surgical approach or the use of neoadjuvant therapy. Though the recommended imaging options in patients with suspected breast cancer is diagnostic mammography, it's not recommended to our patients since she already presented with a large breast mass, and one of the principles behind the use of mammography is an adequate breast compression with that will increase the image contrast, because dense breasts can limit the sensitivity of mammography both for detection of breast cancer and for delineating disease extent. That's why for the choice option for this patient is target ultrasound because of its cost effectiveness and availability. Next slide. So this is just table showing on how imaging is categorized to the patient by red scoring. Next slide. So for the next paraclinical diagnostic procedure is the biopsy. So in patients who present with a suspicious breast mass or a BI-RADS score of 4 and 5, they typically undergo biopsy regardless of additional imaging findings. And the goal of the initial biopsy is to obtain sufficient diagnostic material using the least invasive approach and to avoid surgical excision of benign lesions. So breast lesion suspicions for phyllodes tumor should undergo a core biopsy, which is typically diagnostic. Compared with core biopsy, fine needle aspiration is less accurate if the core biopsy results are indeterminate or if there's a clinical pathologic discordance, and an excisional biopsy should be performed. So core biopsy has 25 to 30% false negative rates when used to diagnose phyllodes tumor. Thus, if a solid mass is a benign core biopsy, but subsequently grows rapidly or becomes symptomatic, an excisional biopsy is indicated. So, but for a patient, excisional biopsy cannot be done since management will differ if the patient has malignant type of tumor. So, fine needle aspiration biopsy, it permits cytologic evaluation, whereas core needle biopsy, it permits analysis of breast tissue architecture and allows the pathologist to determine whether invasive cancer is present. It can be performed in a patient setting in which a 1.5-inch or in 22 gauge needle attached to 10 ml syringe or 14 gauge core biopsy needle is used. So advantages of core needle biopsy include a low complication rate, minimal scarring, and a lower cost compared with excisional breast biopsy. So histologically, phallus tumor are classified as benign, borderline, or malignant based upon the assessment of the degree of stromal cellular atypia, mitotic activity, infiltrative or circumscribed tumor margins, and presence or absence of stromal overgrowth. Next slide. So this is just a table showing the criteria in determining the grade of phallus tumor. Next slide. So once explained all of the paraclinical diagnostic procedures that the patient needs and how the procedure should be done, and if there's an agreement or informed consent from the patient, then we execute this paraclinical diagnosis. Next slide. So this is just showing again the result of the patient breast ultrasound done last June 28, 2022. Next slide. And also the incisional biopsy findings in which there's 3 small pieces of gray to white, irregularly shaped and soft tissue with the surrounding stroma is hypercellular, composed of spindle to elongated cells with round to spindle and hyperchromatic nuclei, in which no mitotic figures are seen in the tissue samples examined, and the patient is suspicious for malignancy. Next slide.
So for the treatment, so the goals of the treatment of our primary diagnosis, which is phyllodes tumor, right, is excision of the tumor, prevent spread to distant sites, and prevent local recurrence. So this image shows the NCCN guidelines for treatment of phyllodes tumor. So as you can see here, phyllodes tumors are given the rarity of phyllodes tumors, treatment principles are mainly based on retrospective studies and case reports. So, according to the guideline, when there is borderline or malignant diagnosis that is established through excisional biopsy or core needle biopsy, they recommend a wide excision without axillary staging. This means that surgical margins of greater than 1 or equal to 1 cm are excised. So otherwise, if there is only a benign tumor or a fibroadenoma result in the biopsy, this only warrants surveillance. So for the treatment modalities, in comparing treatment modalities that is available for our patients, first there is operative, which is again surgical resection. So surgical resection is the gold standard for phylloidous tumors, and the benefits include complete excision of the tumor. So the risks that may come with this is if resection is done with narrow margins. This is such as less than 1 cm. This is associated with high local risk. So the cost, given the range of 100,000 to 250 pesos, and there are only limited capable hospitals that may do the resection. Again, as a reiteration, surgical resection is the definitive management for surgical resection, hindi pala nag-change yung slide. So this is the table of the benefit, risk, cost, and availability of the operative management in phylloidous tumors. And again, as a reiteration, our surgical resection is definitive management. So they can do a breast conserving surgery versus a total mastectomy. So breast conserving surgery is done when adequate margins can be achieved. And most of the time, adjuvant therapy is given to ensure that, again, margins are clean. For benign, depending on the characteristic of the tumor, we associate the margins of the surgery. So for benign tumors, clear margins only requires clear margins but do not require a wide margin or the greater than or equal to 1 cm. But for borderline or malignant phylloidous tumors, there should be at least 1 cm margin, as stated a while ago, that this lowers local recurrence rates. Again, this is just a simplified version of the NCCN guideline. So for the non-operative or the adjuvant therapy that can be given for the patient, first we have the radiotherapy. This is done again when adequate margins cannot be achieved because of tumor location, or again, it is done in conjunction with breast conserving therapy. So the risks include the side effects of brachial plexopathy or lymphedema. So again, the cause is this is just a range, and not all, again, hospitals in the Philippines are capable of doing radiotherapy. Next is chemotherapy, which is systemic chemotherapy, which is given for patients with unresectable metastasis. So the risks of this treatment include its side effects that are common in systemic chemotherapy, such as hair loss, fatigue, loss of appetite, nausea and vomiting, constipation or diarrhea, mouth sores, immunocompromised, and nerve damage. And depending on the chemotherapy regimen will the cost of the medications, and depending again on the availability of the medications and the hospitals that are able to provide chemotherapy to patients. So to evaluate the proposed treatment for our patient, so the plan for our patient is total mastectomy, right? With margins of greater than 1 cm. So again, for giant phylloidous tumors, since our patient has a 15 by 17 by 23 cm mass, complete removal of visible tumors and breast tissue is advised. And the margins should be greater than or equal to 1 cm. Again, since it is supported by studies that wide local excision margins versus narrow excision margins lower the recurrence rates as follows. So in one study, there is 60% of local recurrence in narrow excision margins as compared to wide excision margins with only 28% of local recurrence rates.
Um, ne- next we'll be discussing the prevention and health promotion for our patient. So once again, our final diagnosis is a Phyllodes tumor of the right breast. So for the post-operative course, on the next slide, we found one case report of a local large Phyllodes tumor, and they mentioned the following post-operative course done for that patient. So they did a CBC and it was low, so they transfused blood for that patient, and the drain that was in place was removed 7 days post-op, and they watched out for signs of necrosis and signs of infection on the post-operative side. So we could also do this for our patient. And next, for early detection, assuming that the patient, for the general public, for Phyllodes tumor, as was discussed earlier, middle-aged women and those with diseases such as Lee-Fraumeni syndrome or genetic predisposition such as those genes mentioned earlier would predispose the patient. But to apply this for our patient, maybe we could advise their relatives, but it's difficult to advise patients' relatives since the etiology of Phyllodes tumor is still not fully understood. The next slide would show the local study for Phyllodes tumor, which was discussed earlier. So just to reiterate, in that study done with data from PGH, 80.5% were benign, and upon follow-up, 6% showed distant metastasis, and less than 1% showed a recurrent benign Phyllodes tumor. So next, for screening for our patient, we should screen for metastatic disease, as was emphasized by Dr. Hosan earlier. We should perform close surveillance for metastasis because it is possible in patients with Phyllodes tumor. So here's some information about metastatic disease in Phyllodes tumor. So metastatic disease have been reported in 13 to 40% of patients with Phyllodes tumors. This is from an international review. Phyllodes tumor metastasize most often to the lungs, and tumors that metastasize are typically large, greater than 5 centimeters, or have malignant histologic features. And the mean overall survival is approximately 11 months in patients who develop metastatic disease. So with these data that we could advise for a patient, what else can we recommend for her screening? The next slide would show some suggestions for our patient. So here are some recommendations. First, most recurrences occur within the first 2 years of treatment. Therefore, we could perform history and physical examination every 6 months for the first 2 years, then annually afterwards. So for other patients where a mastectomy is not yet done, mammography could be done every year. But for our patient, this is not applicable because she's going to have her mastectomy later today. And finally, for patients with large or malignant Phyllodes tumors, the
Sir, Lloyd got disconnected po ata. Pero for patients with large or malignant phyllodes tumor, it is recommended that there is surveillance of chest X-ray or CT scan.
Okay.
That's the end of our
Yeah.
case report.
Okay, case report and discussion. Okay. So what okay, can you turn off the okay. Are you back, Lloyd? Wala pa.
Not yet po, sir.
Okay. So what we are supposed to be doing will be a case presentation and discussion of the case, right? Okay. So the reason why I gave you this patient management process, it's more direct to the point, no, in terms of your objective is to discuss the case. Okay. In the past, because you're used to so many other templates, no, it's more of a theoretical discussion, no. So at your stage, interns, okay, next year after you're board, you will now become certified physicians, no, okay. So you'll be doing a lot of problem solving, decision making, and also direct to the point. Do it very effectively and efficiently, and then with cost efficiency or effectiveness as a factor to consider. No, okay. That's why I'm focusing on teaching you patient management process. No, okay. Okay. Now, okay. Let me go at random na lang ito, at random one. I'll try to stick to the flow, okay? So you started with your history. Who presented the history again?
Me po, sir.
Leslie, okay. One thing I noticed in your history is that 4 years, you said 4 years, it was noted, the breast mass was noted at the right side. And then, were you the one who inquired on the, or you got it from the chart? Were you the one, kasi when you do history, you can do it very briefly and then just rely on your physical examination. And then you can go back to your history when there's a need to ask more questions. No? Okay. So in terms of the chief complaint, which is the mass, okay, you mentioned about solid. Okay. You mentioned about solid and then regular border. No? Tama? Okay.
Yes, sir. Yes.
Did you ask for it? Did you ask for them, or what were they volunteered to you?
I asked for it po, sir, nung in-interview ko po si patient.
And then you put it down on your history.
Yes po.
Okay. So you think the patient is capable of determining that? Accurate ba?
Mukhang accurate naman po, sir, kasi nung tinanong ko po si patient how it feels po nung hinahawakan niya. Kasi nung kinento po sa akin ni patient kung paano niya po na-feel na may mass, is fini-feel niya po talaga. Tapos tinanong ko po siya if it feels na solid, na hard, or if parang jelly siya or watery po yung laman. Tapos sabi po sa akin ni patient is sure po siya na solid po.
Mm-hmm. Okay, anyway, okay, you can try, but usually our patients are usually not probably does not have that competency to determine whether it's solid or the border, especially the border, mahirap yata distinguish in border, because even doctors, even you and myself, and even consultants, it's hard to differentiate this, especially the border, solid pwede pa, okay? But at times it's hard to differentiate solid from cystic, okay? The only time that you can determine whether it's cystic or solid is that there's a big mass and then you press on it, it's fluctuating, okay? There's a fluctuant area there, then you call it cystic, okay? So mahirap for the patient. So you don't have to waste your time on that. Ikaw na ang mag-determine during the physical exam. Okay? That's my That's why when you see a patient in the clinic, short lang history ninyo. Okay, go direct to the point. But kung hindi nila kayang sagutin, just try to describe it in your PE, in physical examination na lang ninyo. Okay, that's more reliable than taking the words of the patient as although kasi tinanong mo na, and then you can accept, give them the benefit of the doubt, but you still have to check it, but that will probably, you're going to spend 1 or 2 seconds or even 1 minute trying to get the answer, okay? So that's my comment, and then yung pain, okay lang, okay? pain, no? Okay. So a lot of in your discussions, you mentioned about pain, ganon, di ba? Painless, ganon, no? Usually
Yes.
usually mga tumors, no? Okay. Again, you don't okay, pain madali lang yan, pero it's not reliable also, no? So in your discussion, you said that phylloides tumor, even breast cancer, usually painless, di ba? Okay. So how do you reconcile the two now? That you have a patient complaining of pain, 3 out of 10, 4 out of 10, no? And then in the actual state of the game is that mga neoplasms are usually not painful. Okay, they will become painful only when it has invaded the skin or the bone, no? Okay, but if it's floating on the breast tissue, usually hindi masakit, no? Pag nasasaktan sila, usually it's the rest, the other parts of the breast is the one contributing to the pain. Baka may hormonal changes, but not the tumor itself, no? Okay, okay. So don't waste too much time on that, no? Just go direct to the, when you do your PE, just check whether it's tender or not. No? Okay? And then, kasi in the one who presented sa PE, sinong nag-present ng PE?
Me po, sir.
Ikaw rin? Okay. Well, you did not mention about the solid, you did not mention about the regular border in your PE. Bakit? Which
I
is
was thinking-
very important, ha? Very important yun.
I was thinking po kasi, sir, parang lagay ko na po sa history. So parang magiging
no, you have to put it in your PE. Your PE is very important, no? Okay. As colleagues mo will look at your PE more on the PE rather than on the history, no? Okay. So kasi yung PE mo will be used to you to be used for your pattern recognition. Okay. So outright, sige, I'll jump the gun already. When you have phylloides tumor, the pattern is usually there's a mass there, now, which the typical one, it's a combination of solid and cystic areas. Okay, combination. If it's purely solid, you don't consider or you don't think highly of phylloides, unless it's an early stage, maliit pa, early stage phylloides tumor. Okay. But in your patient, it's a big mass already, now 15 centimeters. Now, if you feel solid and cystic areas combination, you think of phylloides. Okay? So that's why it's important for you to describe it in your PE. There are cystic areas, there are solid areas. No? Okay? Get it? Importante yun eh. Okay. So yung size, although yung rapidly growing size of the mass is a clue, no? A very important clue, but it's not enough. You kasi anaplastic carcinoma or yung pinaka-rapidly growing carcinoma can grow big also, but usually not, no? But it can, no? But the moment you are able to palpate solid and cystic area, yun na yun. 98, more than 90% at least that you think of phylloides tumor. Okay? And then you palpate the axilla. Di ba? Kung walang nodes, baka 98% na yung ano mo. Okay? Just based on that pattern. Okay? So yeah, that's what is meant by pattern recognition. No? You look at the picture, no? Even without the history, kung sinabi lang niya, 4 years ago, I have this mass and then it grows bigger, tapos na yung mga data mo, and then you do your PE, you see these things, a 15 centimeter mass, cystic solid areas with no axillary node, right away you can come out with a diagnosis already. No? Phylloides tumor on the right. That's your primary consideration. Okay? Kung wala cystic area, you start thinking of carcinoma. Okay? Get it? Okay. Now, okay. The patient underwent a ultrasound. No? Okay. So yung ultrasound, walang no mention of cystic areas. In ultrasound, can you review it?
Wait po, sir. For the ultrasound, sir, presents with 8.8 by 9 by 6.5 fairly defined macrolobulated hypoechoic solid mass with coarse calcification, sir.
This was done 5 months ago. It was not repeated.
Not repeated po, sir.
Can you flash it? Can you flash it?
Wait po, sir. Will flash.
Oh, by the way, before we go to the, we're now talking about diagnosis, the paraclinical, no? Okay. So, tapusin ko muna sa history, no? Okay. So, kasi gusto ko natin, when you're in the clinics, no, you don't go through this, ano na, yung routine past history, family history, OBGYN, personal history, no? Okay. So, usually yung mga nakikita mo yung mga consultants, they don't go through that anymore, no? They will do it only after they have a diagnosis, no? Okay. Okay. So parang yung family history, wala namang input, di ba? OBGYN, wala namang kinalaman. Personal history, walang kinalaman, no? So you can omit that for the moment, no? You can past history, you can just say, did you consult a physician before? Okay, yan, importante yon, no? Okay, past his medical history, di ba? Okay. And then if you think that there's something that is relevant in the past history, like a previous operation, then you can ask. Yeah. Okay. But among the four, family history probably is more important than the others. Okay. Then after that, you do your PE. So as I said, when you do your PE, if there are pattern recognition for a phylloides tumor, you stick to that, number one. Okay. Then, so of course, you're not 100% sure all the time. So that's why you must have a secondary diagnosis. No? Your secondary diagnosis will be either, kasi kung clinically talagang phylloides na, no? So you can put as your secondary a malignant phylloides tumor, okay? Primary as the benign, then secondary will be malignant. Kasi may pattern ka na for phylloides tumor. It's that you don't know whether it's malignant or benign. Di ba? Okay? So you can say primary diagnosis is benign phylloides tumor. Secondary will be malignant phylloides tumor. Okay? Palaging ano yan? Palaging it should add up to 100 when you put your primary and secondary. So let's say kung you put benign phylloides tumor, you can say if you put 90% now as degree of certainty, and then malignant phylloides tumor, you can put there at 10% or even lower if the incidence is lower, di ba? Okay, if the prevalence of phylloides tumor is only 1%, you can say or 2%, then you can say 2% ka lang doon sa malignant, 98% ka sa benign, no? Okay. Okay. Then if you put their invasive ductal carcinoma, you have to justify. Now, although it's still possible, but it's not very close to the pattern recognition kasi may cystic area, di ba? Okay. We'll go back to that. No? Okay. So let's look at your. So after your clinical diagnosis, the next question is, do you need paraclinical? Right? So your paraclinical could be ultrasound, mammo, MRI, which you mentioned, no? Okay. So which one will you choose?
For this patient, since the patient already presented with a large breast mass, I will choose targeted. I will suggest to the patient to use to undergo targeted breast ultrasound to assess for the breast tissue and defining cystic masses, also for echogenic qualities of specific solid abnormalities, sir.
Okay, so we're discussing this case from the point of view na ano, wala pa yung ginagawa, ha? Okay.
Yes, sir.
Step by step tayo ngayon, ha? Okay. So you saw this patient, suspicious mo is phylloides, no? And then, but you're not 100% sure, you're not very sure, okay? You're thinking baka it could be invasive carcinoma, then you go for a diagnostic test, no? So you have the option of ultrasound, mammo, MRI, di ba? Sa ngayon, no? Or
Yes, sir.
even isama mo na yung biopsy, no? Okay? Biopsy, so apat, di ba? So how do you choose, no? So biopsy direct to the point, di ba? So it has a 90, more than 90% accuracy rate overall, di ba? Okay, whether needle or core needle or excision, no? So later on, you have dissected the different types of biopsy, no? Okay, but let's group them together under biopsy, and then you compare it to ultrasound, then MRI and mammo, okay? So these three are imaging procedures, no? So which one will give you a more information? Let's put it that way, more or enough information.
Sir, enough information to diagnose such mass is biopsy, sir, as it's the definitive diagnosis for patients.
Sige, tanggalin muna natin mo na yan. Okay, yung tatlo mo na. Yung imaging.
So for the imaging, sir, as I already stated po, targeted breast ultrasound is appropriate for our patients since it's already presented with a large breast mass, and it's also cost-effective diagnostic procedure, imaging.
Okay. Or gusto mo makita kung talaga may cystic areas, di ba? Kasi
Yes,
nakakapa ka ng cystic areas. Okay, kasi ultrasound will be the best procedure to detect whether it's solid or cystic, yung mga ganon, di ba? Okay, compared to mammo, compared to MRI, di ba? So kaya ultrasound pipiliin mo, no? Okay. And then why not mammo?
As for what I have read, sir, mammo is used for screening, also for diagnostic in patients who has a palpable mass, and also for a suspicion of malignancy. It is used in patients for screening for 40 years old. And also the principle of mammogram is to compress the chest, is to compress the breast tissue for adequate visualization. And for a patient who presented with an obvious large mass, it is not important to undergo mammography since it's already as a gross mass lesion.
Okay. Sige, tatanggapin ko yung mga sagot mo. Pero think of the unusual practice ng mga doctors when they see a patient complaining of a breast mass. Okay. Usually, routine yan, di ba?
Yes, sir.
Ultrasound.
Yes, sir.
Have you experienced that?
Yes, sir. Since mammography is the screening of choice in patients with breast mass.
That's what they believe. Okay. Pero that's why what I'm trying to teach you, you have to discern, na? Kahit na may maraming practices na which should not be done, na? Kasi sila basta yung pasyente, okay, kahit over the phone lang, doktor, may bukol ako rito. Sige, bago ka pumunta sa akin, magmamo ka muna, magpa-ultrasound ka. Okay. So the best thing to do is to examine the patient first and then see what is needed, na? Wag yung routine na dekahon, na? Okay. So just like in this particular patient, walang ginawang mammo, tama? Okay, so
Yes, sir.
it's really not needed, no? But kung napunta siya sa isang doktor na ang mindset niya is mammo ultrasound lahat, no? Papamamo niya, no? So, okay, if the mammo was done, what do you expect to see? Density, okay?
Yes, sir. And for patients who has suspected breast cancer, this will usually presents with microcalcifications, sir.
Yeah, microcalcifications, no? Okay. So we're not saying that mammo is completely out, but it may offer some information, but not as efficiently as ultrasound. So you choose one ultrasound, no?
Yes, sir.
MRI can also give you some shadows of the masses, no? Okay. Okay. So anong advantage ng mas resolution is higher than ultrasound, but mahina siya sa cystic areas, di ba? Cystic areas, which you want to look at for the patient, no? To determine whether it's really phylloides. Phylloides kasi may mga cystic areas, no? Okay? Then you input the cost, no? The cost, mahal ang MRI, di ba? Okay? So for this particular patient, ultrasound was done. Tama yun, no? Okay. Then once you had the ultrasound done, you had to interpret it, no? Okay. Don't just don't just accept the readings, the remarks of the ultrasonographer as is, no? So babasahin mo muna and then interpret it kung nag-drive dun sa PE findings mo. PE, no? Okay. So let's look at the at ultrasound. Let's try to analyze it. Ultrasound. Okay, flash mo nga ultrasound.
Okay po, sir.
So if it's phylloides tumor, I would like to see kung may cystic areas. Okay. And then the border is usually maganda because it's movable, no? And then, okay. Yep, okay. There is an 8 point, okay, 9 centimeter fairly defined macrolobulated, which is consistent with your phylloides, macrolobulated, hypoechoic solid mass, indenting the pectoralis muscle. Walang cystic areas.
None po, sir. Last 5 months prior.
Okay, kung may cystic areas, the you would really consider phylloides, di ba? Kung may cystic areas, na? Pero wala siyang nabanggit na cystic areas. So your possible consideration is a carcinoma, no? Kaya sinabi ng radiologist, consider phylloides versus carcinoma. Why do you think he put phylloides as number 1? Why not carcinoma first? Carcinoma versus phylloides. Bakit?
Because of the fairly defined macrolobulated, sir. The border of the
Okay.
mass.
Pwede. Okay, that's good. Okay, so you really have to read his mind kung anong iniisip niya, no? Kasi if you have another situation kung may cystic areas, right away sasabihin niya, you know the reason, phylloides yan, number 1, di ba? Okay. So, pero walang cystic areas, pero he put importance on the border, no? Well-defined border. So, he put phylloides first versus carcinoma. So, you can see that even the radiologists are not 100% sure, di ba? Palagi yan. May mga duda rin sila. So, they put some differentials. Phylloides versus carcinoma. Okay. So, they put BI-RADS 4.
Yes, sir.
Ano yung 4C?
4C means there's high suspicion for malignancy. And
Sino nagdagdag? Ikaw nagdagdag niya?
the impression of the radiologist, sir.
Okay. He specified the 4 into C.
Yes, sir.
Okay. Okay.
So lang naman po.
Yeah. Okay. So this is the original report, huh?
Yes, sir.
Okay. So initially, okay. 4 meaning suspicious. Then he qualified that into 4C. No? Moderate concern. Okay. So you can see may subjectivity doon. Diba? May suspicious, may suggestive, may highly suspicious, may moderately suspicious. No? Okay. Maraming gut feel din dyan sa mga radiologists. No? Okay. So as a clinician, you have to know this and then go back to your patient, no, and then palpate it again, no, okay, and then make a decision, no, okay. Of course, as clinician, ganun din tayo. We're not 100%, no, okay. But at least we now have the aid of the ultrasound to complement our process of decision making, no. Sige, i-off mo na. So after that, so why do you need a biopsy?
It is recommended if the breast mass, if the Byron score is 4, it is recommended to have a tissue diagnosis. And also,
Okay.
biopsy is the,
Can I stop you for perhaps the moment you have a report of the radiologist, don't just accept it as huwag ka
Yes, sir.
susunod right away, na? You have to correlate it, na? Not because the radiologist, kasi palaging defensive din sila, na? They will always say, recommended, ganun, recommended na, okay? It's more of a defensive reporting, na? Okay?
yes, sir.
Napapamahal yung mga pasyente, na? Okay, it will create some anxiety on the patient, na? Ay, operahan pala ako, ibabiopsy ako, na? Okay? Okay? So that's why my suggestion is really for the radiologist not to put the recommendations anymore. Let the clinician do it, na? Decide on it, na? Kasi pag number one, it will cause undue alarm on the part of the patient pag nabasa nila yon, no? Tapos sisihin pa nila yung clinician bakit hindi ginawa, di ba? Sabi ng clinician, di kailangan, di ba? Okay? So ganoon. So okay, a biopsy is needed here because yung ultrasound mo may walang cystic areas, di ba? Okay?
Yes, sir.
So pero but you have the option, you can go direct, right, without biopsy also, because clinically it's phylloides tumor, di ba?
Yes.
Whether it's malignant or benign, no, malignant, you still have to operate. It's the same treatment, total, no?
Yes.
Okay. The only difference would be, are you strongly considered carcinoma? Kasi carcinoma treatment might be different, di ba?
Yes.
Okay. So if the clinician is strongly is medyo mataas, a little higher yung suspicion for invasive ductal carcinoma, then you can do a biopsy, di ba? Okay. Okay. Pero
Yes, sir.
kung phylloides malignant benign lang, wala na. You can proceed with your operation without a biopsy, no? Okay?
Yes, sir.
So nung biopsy siya, okay. So biopsy can be incision, needle biopsy, and core biopsy, okay? Then
Yes,
you
sir.
compare the three, okay? As you mentioned, open biopsy has the highest yield because malaking tissue ang kukunin, no? Okay? And then core, mas maliit, no? Supposed to be higher than fine needle, no? Okay? Okay? So fine needle, lowest, then middle, core, then open biopsy, highest yield, no? Okay? So now, I want to tell you that you can still do a needle biopsy also. Yung needle biopsy mo is, in general, it's not 65. You mentioned about 65%. Medyo mababa yan. Saan mo nakuha yun? 75? 11. Saan mo nakuha yun? 65%.
Actually, sir, I just put a percentage based on the benefits to the patient. Since the patient,
Okay. O sige, that's why
based on the patient.
may kutob ako, mali ang interpretation mo.
Yes, sir.
When you put the B for the selection of paraclinical diagnostic procedure, yung benefit nun, yung goal is to which one will have the highest yield of
Yes, sir.
information. No?
Yes,
Highest
sir.
yield. So at times you have to go back, you have to go to the, kung sa laboratory test, madaling may mga data dyan, di ba? Okay, yung iba wala, di ba? So, but kung walang data, you can, like me, I can input my experience, di ba? Okay, so I can put in some degree of percentage and then tell the patients that these are the usual batting average of all of these things, okay? So if you don't have the data, you can just make some layman's comparison. Pinaka maganda yung open kasi malaking tinatanggal, no? So by tinatawag na subjective probability, no, 98%, di ba? Kasi malaking tinatanggal. No such thing as 100, no? Okay, 98 to 99, di ba? Okay, core needle, probably 97, di ba? Mas malaki. Yung needle biopsy, from experience, it could be, it's usually 90%. It's still acceptable. Kaya nakalista dyan eh. Anything that is less than 90% yield, usually hindi na tinatanggap yan. No? Okay. Most of the time that when you see some procedures, some treatment, no, usually may 90% benefit na yan. No? Okay. So, kasi kung 65 lang siya, wala na yon. No? We don't consider that anymore. Okay. If you can get information with needle biopsy, even with 90%, no, pwede na yon. Okay, it can reinforce your diagnosis, no? Okay, but it all depends. Kung may cystic areas, you don't biopsy the cystic areas, no? You biopsy the solid areas, no? Okay, so with the needle biopsy, what will come out on needle biopsy, the fine needle, it will tell you just presence of stromal, ganon, okay?
Cytology features, sir.
Cells. Kung stromal cells yan, okay na yan. It will reinforce your phylloides. If it says carcinoma cells, iba yun. Carcinoma ang magiging impression mo. No? Okay? So what was done was incision biopsy. So anong results sa incision biopsy? Did they mention phylloides?
No po, sir.
Wala.
They didn't mention po. Yes,
Okay,
sir.
they describe it. Bakit wala?
Yes, sir.
Bakit wala incision biopsy na yan eh?
This biopsy po is done outside the PGH, sir.
Yeah. We expect all pathologists to have
Yes, sir.
to have a good training, no?
Yes, sir.
Good reporting, di ba? Kaya nga kahit na malalaking centers, minsan you really have to check, no? Okay? Just because it's a big center, yung mga well-known center, minsan yung quality control wala, no? Okay? So they should put an impression, no? Okay. Pero anyway, kung walang impression, even with impression, ako, when you are the clinician, you also read yung interpretation nila, yung findings nila. Okay? So ang nakalagay dun sa findings, stromal, di ba? Stromal tissues, gano'n. Tama? Can you read the findings?
Okay, sir. So the specimen consists of 3 small pieces of gray to white, irregularly shaped and soft tissues, measuring 1.5 by 1 by 0.8 centimeter in aggregate. So the entire specimen was submitted for microscopic examination, microsection disclosed, mammary ducts of varying sizes and shapes, lined with hyperplastic reverted epithelium, and the surrounding stroma is hypercellular, composed of spindly to elongated cells with round to spindly and hyperchromatic nuclei, in which no mitotic figures are seen in the tissue sample examined.
Okay, ganun yan. You have to get the best out of it. Meron siyang spindle cells doon. Okay? So, which is consistent with your phylloides tumor stromal, no? So, i-pick up mo yun, no? Okay? So if the pathologist cannot give you a definite statement on diagnosis, i-pick up na lang yun, no? The description. So, it jives with your phylloides tumor, no? Okay? Okay? So after that, so let's say you're 98% sure na, no? Okay. So yung okay, a note about the use of prevalence, sino ba? Regina, ikaw ba nag-present ng yung prevalence? Ikaw yun, di ba?
Yes.
So when I talk about yung clinical diagnostic process, pattern recognition and prevalence, no? You start first with your pattern recognition, no? Okay. Then you input the prevalence, whether it's common or not, no? Okay. Not the yung prevalence of breast cancer in the community, ganon, no? Okay. So example, your primary diagnosis is phylloides tumor, no? Okay. And then, that's why sabi ko, it can be malignant and benign kasi ang presentation niya halos pareho, no? Okay. So you can put your secondary, you can put a differential as malignant, no? Okay. And then, you quantify it, no? So based on the local studies, 85% benign, di ba? So, lagay mo, 85 or even with the clinical, based on prevalence yun, but adding the clinical features, may solid, may cystic areas, you can say 98% ka. No? Okay, certain ka na. Yung 1 to 2% will be your malignant. No? Ganon. Okay? So, but if it's a toss-up between phylloides tumor versus carcinoma, you can say, based on the features, because you more than 90% sure ka it's phylloides tumor, you can put in 10% for carcinoma. Okay? Okay? So it's really up to you to quantitate it based on your experience. Na? Sa ngayon kasi wala tayong libro na that will tell us that how you quantitate it. Na? Okay? So as a rule, when you base your signs and symptoms for your diagnosis, relying on the signs, no? Okay, then you can get, it can be a degree of certainty of as high as 98%. No? If you just base it on symptoms, usually less than 90%. Kung symptoms lang, okay? Okay. Kung based on prevalence lang, lower pa. Di ba? Okay, kasi wala kang added information on the clinical presentation, just a prevalence, no? Okay? So that's how you use the prevalence, no? Okay? Pattern recognition and prevalence. Okay? So, okay. Do you understand that? Kasi importante yung clinical diagnosis. Eh. Okay. So example, dito sa, just to add, COVID. So, lahat may flu ngayon, flu-like symptoms, di ba? So, kung walang COVID, you put flu as number 1. Number 2 could be colds, di ba? Okay. Ngayon, with COVID around, we put COVID as number 1, di ba? Then flu number 2. Okay? Yan ang ibig sabihin ng prevalence, using the prevalence process. Now, which one is common now at the moment in the community or in the particular patient? No? Okay. A differential could be TB, di ba? TB of the breast. Is it not possible? Is it possible, TB? Pwede rin, di ba? Okay. So, but since TB is not so common in the Philippines, more common in phylloides, you put phylloides as number 1, TB as number 2, if you want to put TB. Di ba? Okay. So, but you have to justify your reason for considering TB. No? Okay. Kahit na may konting clue lang that it could be TB, you can put it as your secondary diagnosis. Di ba? But you quantify it. Okay. So the treatment here will be so you have to, the treatment here will be, you assess, it's movable, right? All of you have examined this patient? You have examined this patient? Okay. Movable siya? Very movable. And then, do you have kasi if it's not movable, it's probably fixed on the overlying skin. Okay, looking at the picture, but you will be removing the overlying skin anyway, no? Okay. What's more important is yung base, the base, no? So it's moving over the pectoralis muscles, di ba? Okay. So you can still remove it, di ba? So the operation, the plan of operation here will be the plan of treatment. Okay, by the way, you spell out your goal. Your goal will be to resolve the patient's concern, which is a breast mass, which could be a phylloides, no? Which is movable, no? Okay, in such a way that, of course, yung sinasabi ko, patients will not be dead, no? Will be satisfied, no? Okay, and then with the least local recurrence, complications. Okay, okay. So what are the options? You have surgery, then you have radiotherapy. Just put down the options, no? And then chemotherapy if it's malignant, no? Okay. So suppose that's why it's important for you to come out with your primary. If it's benign, you said most likely we don't need the chemo, no? Okay. Then radiotherapy, will it help in as a primary treatment? Will it respond to radiotherapy? mahina, no? Kahit na based on what you have read, okay, mahina. So surgery is still the best. Ang nababasa niyo, surgery is still the best. So you tell the patient, surgery is still the best, di ba? Okay. Okay. So that's how you compare the three, no? Surgery, radiotherapy, chemotherapy, and surgery. Then you tell the patients that these are the comparison. Okay. The risk for the, you mentioned somebody who talked about the treatment, the risk for surgery, your breast will be removed, wala ka ng boobs. Okay. Then the other side effects will be the complication risk of anesthesia, operations, etc. Which is acceptable, which is mild. Okay. Then for radiotherapy, you're going to get burns. Okay, burns of the radiotherapy. Chemotherapy, you're going to have the side effects of the chemotherapy, but it might turn out to be futile also, not effective. Then the cost. Okay. Okay, regarding the options, sometimes you may have to add alternative medicine. Just to tell the patient, just to emphasize the patient, wag kayo mag-alternative medicine. But you list down under the options when explaining all the options to the patient. I-list down mo as number 4. Tell them the effectiveness is only 1%. Wag niyo sabihin 0. 1% lang. Just to emphasize to them, don't go for alternative medicine kasi a lot of patients nowadays, they go for alternative medicine. Nag-alternative medicine ba itong pasyente ito? 4 months ago? Leslie? Nag-alternative medicine ba ito? Kaya hinintay niya po, naging hindi naman. Okay. So, but we know very well that a lot of patients are going for alternative medicine. Once they have a mass there, alternative medicine kaagad. Okay. So the surgery will entail removal of the entire tumors with a good margin. Okay. Now the margin is as big as possible, as necessary. Saan niyo nakuha yung 1 centimeter? I want to ask.
Sir, based po, based po sa mga study, sa ano din po sir, sa NCCN guidelines, 1 greater than or equal to 1 cm po. At least daw po 1 cm.
This
Tapos
is
sa
for
mga journals
keloides?
din po sir na collated,
This is for
1 cm
keloides?
din po yung, sorry po?
Is this for keloides or for carcinoma? Iba yun.
For phylloides po sir.
Okay.
Yes.
Keloides.
Tapos sa mga collated din po na journals, mga systematic reviews, 1 cm din po yung recommended.
Okay. Okay. So from my personal experience, I would, kung pwede, I'll although nilagay niya more than 1 centimeter, di ba? So usually at
Yes
least
po.
2 centimeters, para mas magandang margin, Okay. Para to ensure na walang recurrence, Baka, to ensure 1% recurrence, Kasi yung report na sinubmit, yung binigay ni, the last one, si Lloyd ba? Okay. So ilang percent yan? 26%? Meron din, di ba? Mas mataas yung less than 1, di ba? Okay. So with 2 centimeters, baka 1% lang recurrence mo, Okay. Okay. Then about the treatment, you talk about, kaya importante yung sa table ko, BRCA, benefit, risk, cost, availability. You have the A, availability. You mentioned about the availability of surgeons who can do it, availability of radiotherapy. Okay. So it's nice to input that because when you are, let's say especially when you're working in the provinces, wala yung mga facilities, wala yung mga competent surgeons to do it, then you have to refer. You have to refer. Okay. And it was put as the last priority, BRCA. Kasi pwede ka pa maghanap ng ibang lugar, di ba? Who can do it for you, di ba? Kaya pero mas importante yung B and R, B and R. And of course, number 3 is the cost. Cost is very important also. Baka di kakayanin, Radiotherapy, ganun din, di ba? You mentioned about availability of radiotherapy. It's true. Kukunti lang yung radiotherapy centers natin sa Pilipinas. Hindi lahat meron, Okay? Okay. About the preventive, okay, preventive, how do you? So you just have, let's say, after the operation, total mastectomy, so you have to tell the patient to exercise the arm. So, okay, the usual complications you mentioned about the infection, the tube drain, you have to remove it after 7 days, no? Usually after, pwedeng ano, basta less than 50 cc per day, you can remove it, na? Okay, on the average, it's about 7 days, na? And then post-op, you have to do some exercise of the arm para the range of motion exercise. And then tell the patients the diagnosis to allay the fear. So benign na, walang ano, pero pwedeng umulit, no? Okay? Not give them the assurance na hindi siya uulit. Tell them the importance of regular checkup, no? Okay? Okay. Okay. So yung how do you check this patient up? The surveillance. So somebody, okay, Lloyd, ikaw ba? You mentioned about CT scan and
Yes, sir. CT scan or chest X-ray are options po mentioned sa NCCN po.
okay.
But maybe we think that X-ray would be more cost effective for the patient, sir.
Well, more cost effective. There are two types of surveillance for mga tumors, no? Two general types. One is the symptom sign and based surveillance. The other one is yung mga diagnostic procedure directed, no? Just like your CT scan, chest X-ray, no? So you can base it on symptoms, no? Okay.
Okay, sir.
So if the patient's not feeling anything if it's malignant, kasi let's say benign, but hindi pa tayo kasi may mga error na baka malignant siya, di ba? May 16%. So the most common site of metastasis is still the lungs, di ba?
Yes, sir.
So you tell the patient, watch out for cough that will not disappear for about 1 month, 2 months, no? And then you cannot explain it, and then come to see me, to see the doctor right away, no? Okay. So if there's cough, prolonged cough, then you get the chest X-ray, no? Okay. Kung wala, none, you don't have to do anything, no? Just monitor, no? And then of course during checkup you have to palpate the area, okay? Look for any local recurrence, no? Okay. So that's what is called symptom sign directed, no? Okay. Symptom. That's also being done for breast cancer, no? Okay. But a lot of physicians are not following that, no? But there are studies showing that it's better to have symptom sign directed surveillance, okay, rather than doing a battery of tests, no? Which will turn out to be negative. And also if it's positive, okay, advantage of battery of tests, you can discover it early before the symptoms, right? Tama, no? Before the symptoms appear, you can discover it early, but long-term effect, they die at the same time. No, for breast cancer, this is for breast cancer. So the quality of life in those with early detection with battery of tests, no, is the quality of life is more depressing, di ba? Kasi matagal siya mentally magsasuffer siya, di ba? Kasi para mamamatay lang sila at the same time, di ba? And compared to the symptom directed, wala siyang nararamdaman, so mahikli lang sa suffer niya, no? Okay? So may studies yan in the past, matagal na, no? It has not been disproven, but a lot of our doctors, even abroad here, ito yung mga community issues, no? Okay. Left and right, no? Mga CT scan, chest X-ray, no? Ultrasound, mammo, okay, etc. Okay? Okay? So, okay, in your particular case, bakit mammo ang ano mo? We're
Sir,
talking about phylloides. We're dealing with phylloides, huh? We're not talking about what do you call that? Carcinoma. Kaya ba ng phylloides?
Sir, for our patient,
Yeah.
we don't recommend a mammography as was discussed by Jansen also earlier. That was we just mentioned it in the report as a general recommendation may be applicable for other patients, sir, who hasn't had a mastectomy yet. But for our patient, we wouldn't do a mammography, sir.
You mentioned about not doing mammography because natanggal na yung breast. Pero may other breast pa siya. Okay. So
Yes, sir.
I look at it this way, okay. So of course, pag natanggal na yung breast, wala ka nang imamamo, di ba? Okay. About the other breast, na? Okay. Or kung sabihin natin na wide excision lang, no? You can have a phylloides tumor not as big as the one that you have in your patient, di ba? Let's say mga 3 centimeters lang, tinanggal lang yung tumor with a wide margin, no? So may breast tissue pa natitira. Okay. So would you recommend mammo as a monitoring tool for recurrence of the or would you rather have ultrasound? Kasi the original pathology is phylloides, di ba? So, food for thoughts yan, ha? So think about it. No? Okay.
Thank you, sir.
So magkaiba yun, ha? Kasi alam natin yung mga mammo, usually we look for the microcalcifications of carcinoma, di ba? Okay. Okay. But not usually not for phylloides. Okay. I'll look it up also. I'm not very familiar with that, but I have not been using mammo for phylloides. No? Okay. So, okay. Okay, I think I have covered everything. Oh. Okay, I think I've covered everything. Any questions? Any comments on the patient management process?
So I was just thinking about the question, and maybe I'd lean more towards what you mentioned, like symptom-based examination. Like there's still a higher chance for a recurrence to be benign if it would recur even. So maybe like it would just add additional cost to the patient to have more tests done if it could be avoided anyway.
Yeah, it can be done. No? Okay. It can be done. I do it in my practice. Okay. Okay. Remember, okay. Kasi magalo yung practice ng medicine na? Okay, kanya-kanyang na? Okay. So one would follow yung the practices of other people para hindi daw sila ma-criticize, no? One would follow guidelines, no, which are not really guidelines lang naman yon, no? Okay. In the end, you also consider the patient's yung welfare, di ba? Yung mga finance, yung mga ganon, no? Okay. So you can use the so-called patient-centered care management philosophy, no? So when you say patient-centered care management, no, you think about the patient, you ask him or her what are her preferences, no? Okay. So don't force all the guidelines, don't force all the things that the other doctors are doing into a particular patient. You can deviate from it as long as you discuss it properly to the patient, no? Okay. Well, that's why I have this the BRCA. You put down all the data there, then you ask them to choose what they want. Okay. If they say I want this one, okay, just make a. I usually in my practice I usually ask them to sign, no, that this is the one that they chose. Okay, based on my explanation. Okay. Okay. It's a nice practice to get the informed consent. No. Kasi medicine is so inexact, madaming variations, marami. If you go to 2 physicians, 3 physicians, kanya-kanyang opinions, di ba? Okay? Then, in the end, it's the patient who will decide, di ba? If you give them the leeway, if you dictate on them kung very submissive yung pasyente, susunod nagsusunod, di ba? Okay? Pero if you let them decide, no, ask them to sign that this one, after explaining sinasabihin ko, I have explained the diagnosis, the findings, and recommendations to the patient, and this is what she agreed on. No? If she agreed on something that is not the usual things that all majority of doctors are doing, no? Okay lang yan, no? Okay, because it's patient-centered. They have a choice, informed consent. Okay, so that the reason why it has to have a signature, because pag wala kang signature, no, na evidence na pinili niya, no, minsan confuse mga pasyente, they see another doctor or they hear another patient and relative saying, bakit hindi itong ginawa sa inyo? Bakit hindi ganon? No? Kasi yun ang, they're used to the so-called trend, no? Kung anong ginagawa ng ibang doktor, gagayahin nila, no? And then, makasisihin ka pa ng pasyente if something happens, no? Okay. Okay. So that's why you must have some signature there that I inform you, I discuss everything to you. This is your choice, no? Okay. So if kung bumaliktad siya, you can always say, eto, pinirmahan mo, di ba? In-explain ko sa'yo, no? Okay? Get it? So use the BRCA. You won't get wrong there. Basta may BRCA, then present to the patient kung anong gusto niya. Okay? You can, when they choose a wrong, yung sa play mo mali, no? I-educate mo muna, no? Rather than agree to it, no? Okay? Then try to convince her or him to get a better choice. Kung saan hindi nila alam, no? Okay? But after this educating them, kung ito pa rin ang pinili niya, isang choice na which you think is not the best, no? Okay lang, just accept it, no? Okay? Okay. Huwag mong pilitin, no? Okay. Okay, any more questions? No more questions?
More questions po, sir.
Okay. Okay. So, phylloides tumor. So, you know how to recognize phylloides. Basta malaking bukol, no? Usually malaki, and then with solid and cystic areas, no? With no nodes. Yan. Okay. More than 90% sure ka na phylloides na yan, no? Okay. So, from there, you make your decision whether what to do, whether you need diagnostic test, kung wala pang ultrasound, if you need ultrasound, okay lang, wag na yung mammography or MRI, no? Ganon. And then after that, operate as soon as possible bago lumaki pang lumaki, no? Baka hindi mo na may isara, no? Okay. Okay. So, there are no more questions. Let's call it a day, but let's have a group picture muna. Group picture taking. Okay.
I'll take na lang po the picture.
So, show your face.
I show po your face.
Oh my God, hindi ako nakapawin.
Remove your mask. Remove your beautiful mask. Okay. One. Sige. 1, 2. 1, 2. Okay.
Okay na ba, sir?
Dali, tingnan ko nga kung na-save ba din niya.
Yes po, sir.
Recorded pala yung mga...
Okay, disconnect ata, Hello po,
Okay.
sir.
Yeah, we're back. Okay. So nawala. So, okay.
Yes, po.
So,
Okay naman po.
okay na, no? So we call it a day and then submit to me, Sandra, yung names of people, no, who contributed. And
Yes, po.
then, dali. The link. I will put it in the chat box. Okay, that's the link for the Olete. Nakita niya?
Yes po, sir. Sir, until when po we can answer? Until when po you need
Last
to
day na
answer?
ninyo nga, di ba? O bukas.
Sa today po, sir, for GS1.
Just one, but you're still in surgery?
Yes po, until December 4 po.
Okay.
Ay, 1 po pala, sorry.
Okay. Ang recommendation ko, take it as soon as possible para you won't, you won't forget, no? Okay. Just if you don't get the perfect score, just repeat it right away. And then the trick here is that yung mali nyo, ilista na lang ninyo, put in a piece of paper. So once you retake it, alam niyo kung anong mali. Di ba? Para second try, tama na. No? Perfect na. No? Okay? So parang pre-test, post-test na rin yan. No? Then I'll give you a certificate of accomplishment also. And then the other benefit for that is that you have bonus points for that. No? If you get a perfect score. Kasi sabi ko, individual grading, di ba? Okay. So, pag yung mga naka-perfect score, may bonus points. Di ba? Okay? So, okay. So, if there are no more questions, let's call it a day. Okay. So, just
Thank you po, sir.
bye-bye.
Thank you, sir.
Salamat, sir.
Bye-bye.